Okay.
So good evening, everyone. So once again, we're meeting for this Shaft Expert Opinion Symposium. And the theme for today's program is Regenerative Andrology, Decoding Male Infertility. So the first speaker, we have two speakers for this program. First one, Dr. Saravit Singh, and second one, Dr. Anna Feskov from Ukraine. And main intention of this program is to bring the experts working in the field of cell therapies and cellular microenvironment and regenerative medicine. We want to initiate conversations so we can have more in-depth knowledge of this regenerative medicine, very specifically to male infertility. So the first speaker for today's session is Dr. Sarabjit Singh. He doesn't need much introduction because he's in a very famous faculty in India. He finished his MD anatomy from the AIMS. He's a Asia certified senior clinical embryologist. He's heading the Artemis Health Institute and the head of clinical embryology and andrology section over there. And he's the current chair of clinical embryology of Indian Fertility Society. And he's the director of the Fertility Academy, which is an online platform which produces hands-on teaching experience for reproductive medicine for the PGs across the globe. And he's received the Champion SR Award for the year 2020. And he's got various accolades. And he's got the best IFS ICBS award at Upper Division. And his areas of interest is academic biology and male infertility. And it's once again pleasure to host Dr. Sarabjit Singh after his arrival at Trichy for our SHART program. And he'll be talking on optimizing a testicular environment, regenerative possibilities for spermio and spermatogenesis. Good evening, sir. It's all yours. You can share the PPT now.
Thanks for the kind introduction. So I'm not into regenerative medicine. Let me just clarify. But yeah, it's something which interests me, and I really read a little bit about it. So I'll be talking on testicular microenvironment and what possibilities are there for spermatogenesis. So with my limited experience, I'd like to share my screen. So can you hear me clearly?
Yeah, it's audible, sir. Please proceed. Perfect.
Screen is also okay. Yeah, just give me one. So the topic for today is optimizing testicular microenvironment, regenerative possibilities for spermio and spermatogenesis. So first of all, this topic was given to me by Dr. Natesh a couple of days ago. And whatever little I could do in this little time I've done, including I feel that the topic is should have been a little differently designed, but anyway, let's start with the show. So testes, if you look at the gross anatomy, they are paired ovate structures which lie within the scrotum and they are located outside the body. And they're suspended by a musculofacial pouch. So I'll just run through the gross anatomy. And testes are connected by the spermatic cord to the abdominal wall and tethered to the scrotum by scrotal ligaments. And at approximately 26 weeks of gestation, testes descend from the abdomen into the scrotum. And this migration is caused by differential growth of abdominal cavity combined with the action of testosterone that causes shortening of gubernaculum. Now, gubernaculum is a testosterone-sensitive ligament connecting the inferior pole of testis with the developing scrotum. So all of us are aware of this. So I'm just running through it. And this descent of testis is to ensure that spermatogenesis takes place normally, which is 2 to 3 degrees below the body temperature. And this is very essential for spermatogenesis to happen. And if the testis due to any reason is maintained at a higher temperature, is simply because of fever, then spermatogenesis is affected and the testis sperm counts do go down. So if you talk about testicular microenvironment, it is defined as a complex milieu of cellular components, extracellular matrix, and signaling molecules within the seminiferous tubules of the testis. It is here that the delicate balance between proliferation, differentiation, and homeostasis is meticulously maintained to support the production of spermatozoa, and the male gametes essential for reproduction. So it's a very delicate balance, and anything, even a minor change in the balance will lead to drastic consequences. If you look at the structure of testis, the testis has a connective tissue capsule known as tunica albuginea. You can refer to the figures for better understanding. This is tunica albuginea. And the inner part of this capsule, tunica vasculosa, is a loose connective tissue, and it divides testes into 250 lobules. So, along the posterior surface of the testis, the tunica albuginea thickens and projects inwards as the mediastinum testis. This area is the mediastinum testis, and blood vessels and lymphatic vessels and other ducts, they pass through the mediastinum as they enter or leave the testis. Now, if you look at the structure of a seminiferous tubule, each lobe of the testis consists of one to four seminiferous tubules, each lobule, sorry, in which sperm are produced, and a connective tissue stroma, or that is the interstitium, in which Leydig cells are the predominant cells. Each tubule within the lobule forms a loop because of its considerable length, it is highly convoluted and actually folding on itself within the lobule. The ends of the loop are located near the mediastinum, where they assume a short straight course. In the straight course, they are known as the straight tubules, and it becomes continuous with the rete testis, which is the anastomosing channel system within the mediastinum. If you talk about Sertoli cells, they are the supporting or sustenticular cells, and they do not replicate after puberty. And they give structural organization to the tubules as they extend to the full thickness of the seminiferous epithelium. And they are located on the basal membrane of the seminiferous tubules and surround different germ cell stages within their cytoplasms. They are the nursery cells. They are prerequisite for initiation and maintenance of spermatogenesis. So when you talk about spermatogenesis, the first thing which comes to mind is not the spermatogonia. It is Sertoli cells actually. It enables seminiferous cord formation, localization of fetal gonad with leukocytes, with gonocytes, as well as function of Leydig cells. An important marker, gene and protein for immature Sertoli cells is AMH, which ensures regression of Mullerian ducts during the fetal development. During puberty, the role of Sertoli cells becomes supporting germ cell differentiation and therefore maintenance of spermatogenesis. The daily sperm outcome therefore clearly correlates with the number of Sertoli cells within the seminiferous epithelium. Another feature of Sertoli cells is the formation of blood testis barrier, which actually provides testis insulation from various products and helps in providing a characteristic microenvironment. So, Sertoli cells generate a special microenvironment in which germ cells may develop properly, and they express the androgen receptors. And also, Sertoli cells convey the testosterone action towards germ cells, which do not express the receptor themselves. When the residual, during the process of spermatogenesis, when the residual body is removed as one of the last stages of spermiogenesis, Sertoli cells phagocytose this excess cytoplasm and are involved in the release of sperm by the modification of apical ectoplasmic specializations. When you talk about the blood testis barrier, as I've already told you that it's formed by the Sertoli cells, and plasma proteins and circulating antibodies are excluded from the lumen of the seminiferous tubules. The exocrine products of Sertoli cells, particularly the androgen binding protein, which has a high binding affinity for testosterone, are highly concentrated in the lumen of the seminiferous tubules, and they maintain a high concentration of testosterone, which provide a favorable microenvironment for the differentiating sperm cells. So we are absolutely focusing on the microenvironment and the contributing channels such as Sertoli cells and the BTB or blood testis barrier formed by the Sertoli cells. And this isolates the genetically different and therefore antigenic haploid sperm cells, secondary spermatocytes, somatids, and sperm from the immune system of the adult male. Antigens produced by or specific to the sperm are prevented from reaching the systemic circulation. And therefore, the blood testis barrier serves as an essential role in isolating the spermatogenic cells from the immune system. So the spermatogenic cells, especially the haploid ones, are considered foreign to the immune system, and so this helps in isolation of the spermatogonia from the immune system. The neighboring Sertoli cells are connected by tight junctions, which further divide the seminiferous epithelium into adluminal and basal compartments, And very characteristically, they separate the meiotic and the post-meiotic germ cells from the blood supply and prevent their immune recognition. Failure of the spermatogenic cells and spermatozoa to remain isolated results in the production of sperm-specific antibodies. And such an immune response is sometimes seen in vasectomy and in other cases of infertility. After vasectomy, sperm-specific antibodies are produced as the cells of the immune system are exposed to the spermatozoa that may leak from the severed ductus deferens. The sperms are no longer isolated from the immune system within the reproductive tract. Coming to the Leydig cells, they are approximately 200 million in number, and they differentiate and secrete testosterone during early fetal life. Secretion of testosterone is required during embryonic development, sexual maturation, and reproductive function. In the embryo, again, the secretion of testosterone and other androgens is essential for the normal development of gonads in the male fetus. At puberty, secretion of testosterone is responsible for the initiation of sperm production, accessory sex gland secretion, and development of secondary sex characteristics. Whereas in the adult, the secretion of testosterone is responsible for the maintenance of spermatogenesis and secondary sex characteristics and accessory glands. So all these facts should be known before you are attempting on, a regenerative medicine or regenerating or, you know, sperm cells and other, because till the time you are normalizing the endocrine and the microenvironment, you can't achieve, even if you inject spermatogonia or stem cells into the rete testes or any other part of testes, you will never be able to achieve a result. So you have to normalize the testicular microenvironment. Fetal Leydig cells are terminally differentiated in the fetus, and adult Leydig cells are the definitive and functional Leydig cells within the adult testes. First, fetal Leydig cells appear in humans at 7 to 8 weeks of pregnancy. This is also known as baby puberty, and then they give rise to adult Leydig cells. And this helps in the masculinization of the fetus. So this is the baby puberty. Leydig cells are active in the when Leydig cells are exposed to gonadotrophic stimulation at puberty, they again become active and they secrete androgen, and then they remain active throughout their life. If you look at the other cells of immune system, if you look at the other cells of immune system and immune privilege of the testis, after onset of puberty, the spermatogonia start to differentiate into spermatozoa, and by this time the immune system has matured and the systemic self-tolerance has already been established. To avoid a fatal reaction of the immune system, adjacent Sertoli cells, they form the blood-testis barrier and maintain this immune privileged environment. Other cells of the immune system are macrophages and mast cells, and their proliferation is seen in various infertile conditions. And in histamine is again a mitogen for fibroblasts, and it leads to testicular fibrosis. Lamina propria and peritubular cells. In the human testes, lamina propria consists of 4 to 5 layers of peritubular cells. And in impaired spermatogenesis, for example, Sertoli-Sertoli syndrome, a thickened lamina propria is often found with no seminiferous epithelium. Coming to the topic of discussion for the day, that is, we are going to focus on spermatogenic cells, which regularly replicate and differentiate into mature sperm. In this cross-section through the testes, you can see that various stages of testicular spermatogonia maturation are seen in a single picture, and they are derived. The spermatogenic cells are derived from primordial germ cells originating in the yolk sac that colonize the gonadal ridges during early development of testes. Spermatogenic cells are organized in poorly defined layers of progressive development between adjacent Sertoli cells. So you can see that spermatogenic cells you can see them spread across the adjacent Sertoli cells. See, these are the various layers of These are the various layers of differentiation. If you look at the basal component, you will see the spermatogenic sperm cells, and as you move towards the lumen, you see that cells are maturing, and you can see the process of spermatogenesis going on. The most immature spermatogenic cells called spermatogonia rest on the basal membrane, whereas the most mature cells called spermatids, they are attached to the apical portion of the Sertoli cell where they border the lumen of the tubule. So these are the most mature cells and these are the most immature cells. When you talk about spermatogonial stem cells, they are the most primitive spermatogonia in the testis, and they maintain a very high production of sperm cells by self-renewal and continuous regeneration of daughter spermatogonia that differentiate into spermatozoa. Their journey is intricately guided by the microenvironment cues provided by neighboring cells and signaling. Spermatogonial stem cells will be increasingly used to understand their regulation as well as in germline modification, including gene correction, enhancement of male fertility, and conversion of sperm cells to biologically competent male germline cells. So this is the area of discussion and the area of interest. But again, a lot has to be done before we can actually achieve something in humans. Till now, the animal studies have been encouraging, but human studies are not so encouraging. Spermatogonia are diploid cells, whereas spermatocytes are haploid cells. So they are passed through a process of meiosis in the mean in. And when you look at the process of spermatogenesis, it includes all events which transforms a spermatogonia into a spermatozoa. It passes through three phases. Number one is the proliferative phase, in which is represented by the spermatogonia, in which the cells undergo continuous cell divisions by the process of mitosis. Then comes the meiotic phase, in which the genetic material is recombined and redistributed. And finally is the differentiation or spermiogenesis phase, in which the spermatids they transform into spermatozoa. The lifelong maintenance of spermatogenesis is dependent on biological competence of extremely rare spermatogonial stem cells, which are capable of self-renewal and production of daughter cells to generate terminally differentiated cells known as spermatozoa. The whole process takes around 74 days, and 300 million sperms are produced daily. So if you look at this schematic diagram, you see that the first phase is the proliferative phase or the mitotic phase. Then comes the meiotic phase, and ultimately comes uh, the third phase, which is the process of spermiogenesis, followed by spermiation. In the meantime, you also appreciate that there is incomplete cytokinesis till the process of till spermatids are formed, and ultimately when the spermatozoa are formed, the cell junctions are broken, the cytoplasmic bridges are severed off. Just a cross section through the testicular lobule, and it shows that several cycles of spermatogenesis coexist within the germinal epithelium at a given time. And I've already explained that basal are immature, whereas luminal are mature spermatozoa. If you look at the hormonal control, it's mainly exercised by the FSH hormone, and which stimulates the production of androgen binding protein by Sertoli cells and ultimately the formation of blood testis barrier. And it is also androgen binding protein is essential to concentrate testosterone at high levels enough to initiate and maintain spermatogenesis, which can be 20 to 50 times higher than the concentration found in the blood. Again, a flowchart which shows that LH is acting on the Leydig cell receptors, which in initiates the development of testosterone, which acts on Sertoli cells, and the process of spermatogenesis is initiated. Whereas FSH, again, it acts on Sertoli cells and leads to testicular fluid production, and intracellular androgen receptor proteins are activated. Now, what are the factors which are affecting spermatogenesis? Simple dietary deficiencies of vitamin A, B12, C, carotenes, zinc, and selenium, they can bring down the sperm levels. Environmental factors such as rural men are found to have higher sperm count compared to urban men. Developmental disorders such as cryptorchidism, hypospadiasis, Systemic diseases or local infections. Any infection involving the testis has a bearing on the process of spermatogenesis, and such as fever, kidney disease, HIV, other viral infections. Any reason which leads to elevated testicular temperature, such as sauna bath repeatedly, or even a fever which affects the process of spermatogenesis. So the history of fever is very important when you're analyzing a semen sample, and you should allow the person to should be analyzed for at least after 74 days, rather 2 to 3 months, and then a proper count has to be concluded. Any exposure to steroid hormones and related medications can be detrimental. Toxication agents, any ionizing radiation, alkylating agents. Therefore, non-dividing Sertoli cells, Leydig cells, and reserve sperm cells, which demonstrate low mitotic activity, are much less variable. Anything which is dividing slowly are obviously much less vulnerable to the compared to the actively dividing spermatogenic cells. Regenerative possibilities of spermatogenesis and spermiogenesis. Now, there are various experiments which have been done, such as spermatogonial stem cell transplantation and microinjection of donor sperm cells into seminiferous tubules of infertile males was first reported using mice in 1994. And when donor testicular cells from fertile males were injected into the lumen of seminiferous tubules of an infertile male, some donor cells migrated towards the seminiferous tubule periphery, passing through the tight junctions of Sertoli cells, which form the blood testis barrier. So when they were injected, they could cross the blood testis barrier. This is the schematic diagram which shows that the stem cells were prepared using MECS and transplanted into the testis. And after 2 months, donor cell derived spermatozoa appeared by 2 months after transplantation, and the donor derived sperms were morphologically normal and were able to fertilize eggs. But these were animal studies. Another experiment which was done, they injected the donor germ cells, ultrasound guided, and the first site where they injected was they were forced into the rete testis from the injected tubule and then enter other seminiferous tubules. So this is the first site where it was injected, and the second was injected directly into the rete testis B, which fill the rete and flow into the seminiferous tubules. But when the injection pressure is too high, some leakage was found to be seen. So they designed another method in which they went through one of the efferent ducts and then threaded into the rete testis in a retrograde direction. That was the C part. And again, they did get success in this method, but some leakage and some cell suspension can leak from the insertion side of the micropipette, and seminiferous tubule filling 90 can be achieved routinely. So again, these methods may be even more difficult in humans. So human studies are definitely awaited. I would like to introduce a term known as spermatogonial stem cell niche. The self-renewal and differentiation of stem cells must be very precisely regulated, and extrinsic and intrinsic factors are involved in this. The surrounding microenvironment of stem cells is called stem cell niche, which provides extrinsic factors for maintaining stem cell competence. The testis cells transplantation technique was originally developed for mitochondrial stem cell transplantation and evaluation, but is also valuable to investigate and the biological function of SS mitochondrial stem cell niche. So it was found that SSC niche it was tried in pups in adult mice, and the number of spermatogonial colonies generated in pup testes were 10 times higher compared to adult testes. So the young will respond much more and much better. And they concluded that SSC niche in pups is more accessible and supportive of transplanted SSC than in adults. Conversely, aged testes are less supportive of transplanted SSCs or spermatogonial stem cells compared to young. And they also carried an experiment in which they serially transplanted SSCs into recipients over a period of 32 months. They gave 8 injections, and they found that serial experiments they could achieve the same success as they achieved in a young pup. So they recommended that see for it's like a testicular rejuvenation, So they are recommending serial transplantations. Male infertility, either it can be congenital where the mechanism is unknown, or it can be age-related degeneration of spermatogenesis, which is caused by defects or dysfunction of germ cells or their microenvironment. So this was another experiment carried on in rodents in which they transplanted spermatogonia, and they transplantation of Sertoli cells was also done, and there is a I don't want to go into the details of this because it's a rodent experiment, and but this experiment was used to elucidate the mechanism of genetic defects in spermatogenesis and to restore fertility in infertile males. Mice with SID mutation do not express membrane-bound form of KITL on Sertoli cells and have no spermatogenesis. So when tested cells from adult SID mice were transplanted into wild type recipients, donor-derived spermatogenesis was achieved. This indicates that SID germ cells, including SSCs, are normal and stimulation by membrane bound form of KITL is required for spermatogenesis. Transplantation of Sertoli cells into the seminiferous tubule can also provide an approach to restore fertility in some infertile males. In addition, transplantation of Sertoli cells from infertile mice into uh, infertile SID recipient mice restored endogenous spermatogenesis and fertility, demonstrating that functional transplantation of Sertoli cells is also feasible. So even if you transplant Sertoli cells, they can also induce differentiation of sperm cells. Human SSC, it is found that culture of human germ cells is very difficult and very challenging, and any conclusive existence of human SSCs is also inconclusive. Several putative human spermatogonial markers such as PLZF, GFRA, etc., are not reliable to identify human spermatogonia. So the research is on to identify more reliable human SSC specific markers. And you look at the cell-based therapies of non-obstructive azoospermia using, some various modalities were used, such as spermatogonial stem cells, embryonic stem cells, mesenchymal stem cells, but each one had their own share of positives and negatives. I think uh, the best results were obtained by using mesenchymal derived stem cells and decidua stem cells, which had no major side effects or no major concerns. But in the end, I would like to conclude that understanding the intricacies of testicular microenvironment is not only essential for unraveling the mysteries of male infertility, but it also holds profound implications for men's reproductive health. Disruption to the delicate balance of cellular interactions, hormonal signaling on environmental factors within this uh, microns can lead to a myriad of reproductive disorders, including infertility, hormonal imbalances, and testicular pathologies. Spermatogonial differentiation is essential for spermatogenesis and male fertility, but is also a very highly complex process requiring execute extrinsic and intrinsic instruction to properly control the cell fate. The mechanism responsible for executing the earliest phase of this differentiation cascade, stem cell commitment to a progenitor type, have been the most elusive. And consequently, new studies that can separate cells undertaking these alternative fates will help resolve long-standing questions in the field. And ultimately, knowledge of such processes will permit insight into the etiology of certain types of male infertility, such as non-obstructive azoospermia, as well as revealing new therapeutic avenues to address naturally occurring defects in sperm production and mitigate the iatrogenic male infertility. Example as rising due to age or cancer or intervene for male contraception. Thank you so much, and I'm open to any questions.
Thank you, sir. So thank you for providing insights in the testicular histology patterns and adding more and more of valuable contents at the end. So let us reserve the questions to the end in the Q&A session. So we are having the speaker waiting for this to deliver a talk. Shall we proceed further, sir, with the next talk? Yeah. So I'm making Dr. Anna Peskova to make a co-host. Dr. Anna, if you're there, please, you can switch on the video.
Thank you. Should I try to share my screen?
Yep, yeah. So I just make a small introduction about Dr. Anna. Dr. Anna is from Ukraine. She's graduated from Kharkiv University. And she's quite, she's in various researches, various the presentations in various international conferences. And she's holding a clinic called as Feskova Clinic, where they are doing multiple research and therapies based on regenerative medicine. And they're primarily an IVF center, but they're having their own stem cell facility also. So, Dr. Anna, a pleasure to have you here, and we have to hear from you.
So do you hear me well? Do you see my screen?
Yes, we can hear you. I can hear you well.
Yeah, great.
Your video is not visible. If you're intending to share the video, then it's not visible. It's up to you.
Don't you see the video? Let's try is it okay?
No, you have switched on the yeah, now it's visible, but we're not able to see the slides. Maybe you need to share the slide only with now it's visible. Yeah. Please proceed. Yeah.
Is it okay?
Perfect. Yeah, perfect.
Great. So shall I start?
Yeah, please. Now the video is off now. Anyways, please proceed.
Yeah. That's strange. Maybe because of the let's try one more time.
Yep.
Do you see me?
Yes, I can see you. Perfect.
And you see my screen, yeah?
Yep.
Great. So good evening. I want to thank in advance for this bright introduction, and I'm grateful for inviting me to the guest lecture to share our work. So what I want to start that I'm a reproductive specialist in Sanemet Reproductive Clinic, and also I'm a junior researcher. The topic you gave me as a representative therapist in male infertility, and that's a really huge and also motivating field for clinicians for research. And let me start with introducing what we do in our clinic, and firstly share the lecture plan that I'll try to follow according to the timing that you gave me. So Sanemet Reproductive Clinic is one of the first IVF clinics in Ukraine. We're helping couples to become parents for more than 30 years, and the main specialization is gynecology, ART, especially IVF, urology, and surgery. We have two branches in Kharkiv and Kyiv, that's the capital of Ukraine. Despite our clinical work, we develop biotechnologies, and we have our own cryobank, and also we run our own studies, in particular about add-ons, what we'll talk about tomorrow, and potentially that can improve in general final results of the work of our clinic. So the structure of my lecture. Firstly, I'll talk about some theoretical points. After that, we'll move to approach that we use in our clinics. And finally, I'll talk about technologies we use and the regenerative potential technologies as PRP and stem cell therapy. So infertility is really a growing problem, and the last years are still giving us a sad statistic despite the developing technologies. But we reproductologists try to face these problems. So when a couple enters clinic with a complaint that we can't conceive, from this moment, the future tactics of the treatment will be based on rigorous, precise analysis, also age, duration of the problems, and of course, diagnostics. And all these things are administered individually. Men and women, they are a couple, and when they come to the clinic together, so doctor treats them in conjunction, not women or men separately. And because of our intermediate and transitional aim to get spermatozoa from men and oocyte from women. And after that, our goal is to obtain healthy embryo and, of course, finally, pregnancy. And now we'll move into the male infertility. It occurs because of different reasons. There are many alternative classifications, not only that is on my slide. Also obstructive, non-obstructive, genetic, immunological, different traumas, and nowadays important and really weighty factor that is difficult to treat. It is professional harm that cause sperm production problems and stress, especially now in Ukraine when it is war in our country, and military man who is planning a child, a family, they have a strong decrease in their sperm parameters. And in different situations, because of the anamnesis, clinical picture, their desires, we started to treat according to these initial parameters. And it can possibly lead to IUI, IVF, or IVF plus ICSI, and if it is needed, PGT-A, the biopsy of the embryo. And now, one of the regenerative medicine technologies is platelet-rich plasma. It is a small part of the common treatment that is used in male infertility treatment. As I recall, according to the last draft of ESHRE recommendations, PRP was not recommended for an active treatment in male patients, but previous years, I also noticed that ESHRE and ASRM, they actively improve reports on this topic. So this possibly can be a good sign. So patients will not look suspiciously queerly when they hear platelet plasma, like, what's that? I don't want to do it. So PRP is supposed not to urge any side effects because of because it is autologous material. It won't cause any allergy. So that's safe, and that's a really good advantage. And also PRP is still financially affordable in comparison to other types of treatment. But a greater effect we have received when using therapy with medicines prepared from fetoplacental complex in comparison and simultaneously with the standard treatment, like stimulation of spermatogenesis, antioxidants. So this is also combined. And I want to present our recent study on platelet-rich plasma. And the study question we prepared, it was is the intratesticular injection of PRP allows improving sperm parameters in men with severe oligostenozospermia. We had in our group 30 infertile men with the oligosteноteratozospermia who underwent intratesticular injection of autologous PRP in period during 1 year from December 2021 to December 2022. Men with obstructive form of azoospermia were excluded from this study, but sometimes we use PRP in treating men with obstructive azoospermia, combining with the other methods. But in this case, they were not included in this study. And middle age from 18 to 47 years. We analyzed semen in all samples according to World Health Organization guidelines, and we assessed morphology and Papa Nicolau stained sites using Kruger strict criteria. And about observing sperm parameters, they were compared in a period of 6 months, half year, before the injection. About preparing and blood sample expiration, now we use only a special kit for PRP, and in all cases, we've collected blood on the same day of an injection from the forearm vein. And after that, PRP was centrifugated and it was put to the anticoagulant containing tubes. So also we measured the final concentration of platelets in this tube, and it was around 1 million in 1 milliliter. And moving to our results. So there were the next average sperm parameters that we've observed. We had observed sperm motility, sperm concentration, and normal sperm morphology. So the sperm concentration was significantly higher in the 6 months after intratesticular PRP administration, more than twice, as you can see, and there was no significant effect on PRP application on sperm motility and normal sperm morphology. Of course, large RCTs are needed to confirm the effectiveness of PRP therapy, not just a few medical centers that perform this research by themselves. So we could say, yeah, that's valid, that will 100% improve sperm parameters in our patients. So now we're moving to the most interesting part of my speech. It will be one more regenerative therapy techniques. We're moving to the stem cells, and to start with, to give you the more deeper understanding of how it works, how it presumably works. So it's already known that immune impairment starts much more longer before any common symptoms of aging. So stem cell therapy helps to fix it, presumably, or even on subcellular level. And what is stem cell therapy? That's an approach that based on transplantation of cells and also their bioactive molecules, maybe in preceded medicines, drugs into the body that have injury or trauma with the purpose of its treatment. So the targets of stem cell therapy. It is temporary replacement of organ or tissue that now can't work properly. Second is stimulation of own progenitor cells that's precursors of cells that are fully working in our body. And the third target is formation of the cytokine pool. It is proteins, peptides, bioactive molecules that give short distance, short range regulation of intracellular and intersystematic interactions. It helps our own cells to activate and communicate between the cells more effectively. So I haven't translated, sorry, I'll do it now. So the causes of the aging, they are studied really effectively and thoroughly now, especially when you go to PubMed or ResearchGate. You'll see a lot of works, studies, and research on this topic. So it is can be the change of intercellular interactions, unstable genomic problems, telomere aging, also dysfunction of equilibrium of proteolysis proteins, problems with recognition of the nutrients, so cells just don't remember what they need to functionate, mitochondrial dysfunction, and also a cellular aging. As I recall, when a newborn, he has one stem cell per 10,000 somatic cells. When a person is 16 years old, it is one stem cells for 100,000 somatic cells, and in adults, it is more than 1 million somatic cells only for one stem cell. That's how aging just simply in these slides can be explained. But how understand what's the main problem of aging in individuals? So it is known that aging starts from the endocrine system, and the depletion of endocrine potential is quicker decreasing with aging. The bright example of it is women feminine reproductive organs, especially ovaries, when we say that reproductive age is not even up to 60 or 50, and still it is decreasing, and this aging starts with endocrine systems. And here is a clear example of this slide. This slide deeply explains the depletion of regulatory mechanisms with the age that is followed with the hypothalamic changes, and we know that hypothalamus is the king of endocrine system. So one more example, it is the adaptation for thermoregulation. Older people, they easily overheated, or they easily get hypothermic, and also the restore of body temperature after this flexibility is delayed in comparison to the young people. And I want to point out how different physiological levels interact between themselves, and on which level can doctors work and directly influence to observe changes and make conclusions. For sure, it is endocrine level, but we don't have to forget about the other levels that are mentioned on this diagram. Probably stem cells are exactly influencing on these levels, because they connect our cells and push their potential for interaction and regeneration. I want to recall stem cell features. It is proliferation, migration, homing, and differentiation. Differentiation is held depending on the speciality of the injured tissue or organ. And on this slide, I want to show you, you can scan QR codes and see how many research are held now about hematopoietic and mesenchymal stem cells. And we are moving to the cord blood. It is it's containing the biggest concentration of stem cells, and in our cryobank in Kharkiv, Ukraine, and in Kyiv, we produce and prepare medicines from cord blood, from placenta. We have 6 medicines, different type, different concentration, different bioactive markers, and medicines that are prepared from feta placental complex and cord blood stem cells. They are extremely rich for these biologically active substances, so that can help to make an analysis of the medicine and then to use it properly in clinical practice. And it is the table that shows which medicines we produce, which medicines we prepare. We have different types, like cell-containing drugs and not cell-containing drugs. It is cell-containing. It is concentrate. It is fragment of placenta, and also suspension. They have the bigger concentration of stem cells. The other medicines, they contain biological substances, so proteins, hormones, cytokines, etc., etc. This is the scheme how to prepare and how we produce these medicines. They're not just we take in placenta, we got it, and we take it to the jar. We need to place this material into quarantine. We need to be sure that it doesn't have any infections, any abnormalities, so it is fine to use in future clinical practice. Also, stem cells, they have a great potential for long-term adaptation and the regeneration in general, for updating structures on subcellular level, like atoms, molecules. They are help to rebuild and restore adaptation ability of the organism. And the most important thing is that they work depending of the functional needs of the organs that are injured and of the body in general. Also, I want to share an analysis of hormones in placenta cryostruct. It is one of our medicines that we prepare in cryobank, and between DALT serum. What is interesting, I want to draw your attention to the concentration of follicular stimulating hormone and human chorionic gonadotropin. That's really more higher concentration in comparison to adult serum and about our clinical trial on stem cells. It is being held. We don't have a final results yet, so I can't share it now. But this type of therapy is already giving a positive result. Sometimes I'm even wondering the possibilities it holds. So that is our slide that shows how we treat pathospermia. It is prescribed really individually. Not every man needs this push for his reproductive system. And the first it is insertion, transportation of placental fragment. It is performed only once, and then in 1 month we prescribe suspension of cord blood. It is injected intramuscularly twice, and again in 1 month we use plasma cord blood, from one day to another, one by one. And also, I want to say that human body is not a simple organism, and with a deeper understanding of its function, we can get better results. So that's a point to enlarge our horizon to complex approach for the person's organism. Also, I would like to share an extremely interesting fact. Have you ever been lost in a thought if the sex of the placenta? Yes, it is, and there are strict differences in bioactive substances concentration between female and male placenta. So now we started to investigate new schemes of treatment depending on this feature. So thank you for reaching me out and for invitation for this lecture. I hope you've taken away interesting messages and ideas for your future research and clinical practice. You can find on the slide my personally contact details and also links to find our clinic. So I'm delighted to get in touch, create mutual collaboration, and also to explore opportunities of male infertility treatment and regenerative medicine. Thank you.
Thank you, Dr. Anna. So we're having, I invite the audience to ask questions. You can unmute yourself. You have send the questions or the messages. Dr. Anna, you can disable the screen share, so the video is visible now. Yeah.
Is it okay?
Yeah, but you can start the video. Yeah.
Do you see me now?
Yeah, perfect. Yeah.
Great.
Dr. Sarabit, sir, you're there? Dr. Sarabit Singh?
Yes, sir. I'm there, sir.
Okay, fine. So there is one question for Dr. Anna from the audience, Dr. Siddiq. So he's asking, and how do you inject PRP into testes? Whether you give spinal anesthesia or a local anesthesia?
We inject PRP with a sedation, like propofol only. But that depends individually on the patient. If they have some contraindication to this procedure, we manage the anesthesia according to his features of his health.
Makes sense. So it's basically an intravenous sedation. It's a short GA. So it must be a daycare procedure, right?
Yeah.
And the second question is there a role of platelet-rich plasma? Okay, that is what the whole topic was. And Deepak Jumani is asking, how do the nutraceuticals and other compounds, that is Baxocyl, how do they increase the sperm count? Because basically he's asking how do they basically nutraceuticals like a, a CoQ, those drugs, no? So how do they increase the sperm counts?
Which dose or
No, he's asking in general.
didn't finish this question. Sperm count in our recent research in PRP, you mean?
No, he's asking a general question. You can skip it or you can answer it. So because it is not to your topic, PRP.
So he's asking you whether antioxidants and acetyl CoQ and other compounds, can they increase the sperm count? Would you want
You
like
mean like conventional therapy of
yes,
male
conventional,
infertility?
yeah, acetylcholine and CoQ and other
Uh,
nutraceuticals.
we never prescribe only PRP. It is only like an add-on to this conventional therapy, to the hormones, antioxidants, vitamins, and so on.
I want to add this question to because we're having an expert histologist here and the chief embryologist here. What is the whole idea behind sperm count development? Because will there is any possibility that we can increase the sperm count? Because whenever we see the semen analysis, the count always varies. So there is a trend in the few centers, or even many centers, that they give a drug and the sperm count has become X, that is the previous X plus the current X being increased. But what is advantage? Because it is not being translated into a offspring. So please add your experience. Whether is there any underlying histopathology being changed, or is it an outward count? How it is happening, sir? Whether PRP or Nutra, what? Please share your understanding of this.
You try to ask me about our final results, but this study, it was carried from December 2001, December 2022, and after that, this war started in our country, and some of the patients who underwent this procedure and were included in this research, they are still have some of them are lost, some of them continue their treatment, some of them just made cryopreservation of sperm, and some of them just moved to other parts of our country, or they're somewhere all over the world and continue their treatment in other clinics. So now the tale is unfortunately lost, but in our stem cell treatment, we start it like preciously to make this research during the war, and we collect all the information for future study to make everything properly and publish it with the results of pregnancy, also biochemical pregnancy, clinical pregnancy, and of course, we would like to show a live birth rate.
So, do you want to add something with respect to my question?
Yeah, Dr. Natesh, it's a good question. It's a very frequently asked question. And honestly, I mean, we have never seen wonders happening with sperm counts. The only difference we see is the difference in evaluation of sperm concentration across various labs. So if you have a baseline, if the sample is poor, it's oligoestino kind of a sample, then you should at least repeat it 3 times over a period of 2 months, and then conclude whether it is actually oligo or whatever the pathology you see in the first. If even on one occasion the sample is found to be normal, then there is no intervention which is required. it is always advisable to freeze that sample and, carry on your IVF, ICSI, IUI, whatever you are trying to, do plan for the patient. But these medicines, they might work. There is a lot of literature in the offing, but honestly, in my practice, we have never tried PRP. Dr. Anna, she's a better judge of her trials and her use of PRP and other immunomodulators. And I don't think it's going. I think the best will be to do some animal studies and actually see the testicular architecture, whether it is able to improve the histology and it is able to produce Leydig cells, which eventually produce testosterone. And you have to eventually look at the testicular microarchitecture to look for any improvement in sperm production, because it's all happening down there. So till the time you are able to actually demonstrate any considerable improvement in the testicular microanatomy, till that time all improvements or decline can be considered as normal variations. The second point is there is a lot of talk about that these antioxidants and nutraceuticals, they don't improve the count, but they improve the sperm quality. So the embryo will be better. So
What
that
do you
is
mean
some
by the sperm quality, sir? Very
sperm
specifically, what quality in
quality,
sperm should
because
improve?
they are antioxidants, so they will prevent any oxidative. They try to neutralize the oxidative damage. Any ROS-induced oxidative damage is neutralized, which can actually lead to a better embryo formation. It can decrease the likelihood of aneuploidies also, if it's a case of high DFI. And then you can obviously, if it's a demonstrable high DNA fragmentation index, you can adopt techniques like microfluidics, put the patient on 3 months of antioxidants. All these things are recommended. But again, we have done it with patients of DFI. DFI has to be measured with a flow cytometric analysis, and somehow it works up to 30%. DFI can be managed with nutraceuticals and lab techniques. The moment it is above 40-45%, it becomes so difficult to manage it. Dr. Anna, I would like to have your views on this.
So do you hear me well? I also I've seen a question in the chat about
No, he is asking.
those.
That's me. So he is asking, what is your view on improving the sperm quality? Because in your center, which is an like good old center, high DNA fragmentation, is it being improved by the antioxidants?
For sure, that depends on the level of fermentation. So, if it is the first visit of the patient to the clinic and he came, he did the analysis of, he did a spermogram for the first time in his life, and it is high level fermentation. There are no normal forms. There are like a total bad analysis, we will try to treat it with antioxidants and also vitamins, and then we will in 1 or 2 months, that depends of the doctor's prescription, check the spermogram to understand if there are any improvements. And as I said, if this man came in the clinic for the first time and he never done a spermogram, and we also need to exclude the genetic causes of this sperm state, because if he never had spermatozoa in ejaculate, so we unfortunately don't have what to work with. So that really depends on his anamnesis, and in such difficult cases, doctor can prescribe genetic testing, carrier mapping, and so on. But if we know that previously patient maybe once or twice this spermogram, and he had normal parameters, let me say parameters that we can work to take it to the embryo lab and to try to create a healthy embryo. That's why we can, in this case, we can use PRP, or if the situation is worse, we can use stem cells, because we know that he had spermatozoa. It worked like a few years ago or many years ago, we don't know. And after that, we will try to reactivate and like blow a new life to his pool of like dormant follicles in women, and also to influence with this view to his spermatogenesis. As the previous speaker mentioned, that spermatogenesis duration is 74 days, and there are simultaneously run a few cycles of that. So we need to observe and check if they're maintaining this situation for better, or it just doesn't change at all. And the interesting fact that when we for month 2, 3, 4 we don't get positive results, any positive changes, and after 4, 5, 6 months it is spermogram starts to become better in some parameters. That means that this man has more severe impairments of spermatogenesis.
So 2 things I understood. You mentioned that after giving PRP, DNA fragmentation might improve. This is one claim. And second, I understood that we need to wait for 6 months, correct? Few months can improve. A few men can improve much earlier, but it takes many times 6 months. So we need to wait for 6 months to get a better results. Correct?
Yes, in this study, we've checked this protocol that the break between first and second spermogram should be 6 months. In our previous study, we did spermogram check each 2 months, twice during the half year. So that depends, that really individually. Not everyone should wait for 6 months. There are, from a clinical view, different types of patients, and a lot of them just don't want to wait for so long.
So only one injection is required, or should we go for frequent injections every 14 days or 74 days?
You mean PRP every 14 days? Like
14 or 74 days.
Like a lot of PRP, and I don't think that injection of PRP is relevant every 14 days, because it can be like an overload.
So how much time can we give frequency with the experience? 2 months or 3 months, or one dose is fine?
2 months.
So every 2 months we can give a booster dose, like PRP.
Yeah, that's a better boost, just not to waste time, just not to overload patients with treatment, with anesthesia.
So you decide upon the volume, so based on the testis size. For example, you give 1 ml PRP or 2 ml PRP. Is it based on the testicle volume, initial testicle volume? How do you choose the?
No, we don't make this correlation before each procedure. Every patient undergoes andrology checkup, and to exclude all the causes that can grow into infertility. So we do not measure testis volume, but It is the ultrasound performed to each patient before that. And if there's something wrong, it will be a contraindication for this procedure, just not to make like 2 milliliters or 1 milliliters to the small testes.
Okay, 2 ml is the maximum which you can do. You don't proceed beyond that, 2 ml.
Do you make 2?
No, I just heard a 2 ml, 1 or 2 ml. You said 1 ml for the small testis, and on average, you can give 2 ml per testis. How much water do you inject PRP? Is it 2 ml?
We use 1.8, 1.7.
Okay.
What is the site of injection, Dr. Anna?
That's on the doctor's opinion. It is decided during the procedure, the site of injection, and usually it is like 1, 2 shots.
No, the site of injection, the point where you inject.
The point where you inject all the testis.
Into that depends on doctor's view on this patient. That's individually.
Okay, so have you given this therapy for azoospermia patients? A couple of audience have asked.
Only in complex treatment, but for a zoospermia patient, it's better to use stem cells.
So your claims, sir, because you have seen multiple patients going for, having this the testicular, you would have teased the tissue, and you know histology also. So how do you see that we can rectify this issue by giving some cellular therapies? What should what changes are required? Your experience on
What
this?
changes? I didn't hear you quite
Okay,
well
this
now.
okay. So this is I was asking Dr. Sarabjit. So he being a histologist and embryologist. So what changes do you see, sir, in patient with azoospermia, and what changes can we reverse, intend to reverse, so that you get the sperm during the teasing?
See, if it's a case of non-obstructive obstructive azoospermia, the testicular architecture is similar.
Yeah, understood.
Okay, but if it's a case of non-obstructive azoospermia, then you have to, look into the cause of it. It can be a Sertoli cell only syndrome, in which I described in my lecture also. The membrane, the lamina propria is thickened. There are absence of any spermatogonia cells. Only the Sertoli cells will be present. So in these cases, I'm not sure, but then I did mention a study of rodents where they have achieved on injecting of SSCs, they have achieved some kind of morphologically normal sperm population. But again, to translate it into humans is a long way to go. And
So
yeah.
yeah, please.
So other causes of non-obstructive azoospermia, you have to look at the testicular architecture. And but I've actually not read any therapy helping people with Sertoli cell syndrome, or uh, if there is a maturation arrest, then nothing in this world can trigger break the arrest and make the sperm be mature.
So
So, but
can
again,
a YCMD can do
injecting
this, sir?
donor spermatogonia or donor stem cells may or may not work in cases of maturation arrest, because ultimately they also have to, they are also following the same signals of differentiation, which is present in the testicular milieu.
Okay.
So whether the same signals which are unable to mature a particular, lot of sperm, will they be able to mature a donor sperm? Because donor sperms are not bringing in their own milieu as such. You're only giving the spermatogonial sperm cells, stem
Mm.
cells.
Mm.
This has to be seen. It's a very vast, very what should I say? Very hazy topic, I'll say. It's not a very clear topic. So maybe Dr. Anna can throw some light on it in cases of non-obstructive azoospermia. Have you tried any therapy which has helped the patients?
Do you hear me?
Yeah,
Yes.
clearly. Yeah.
Yeah, fine. In azoospermia, we try to correlate with the potential abilities of men's organism. There are a few predictors. Also, we assess its hormonal profile, like to understand if we can do something to achieve even one normal form and active motility spermatozoa to create an embryo, but using just PRP or just stem cells or conventional medicines, maybe in some cases it won't be useful, and even when patient is strongly insisting to do something to create a fully natural embryo for this couple. So unfortunately, in some cases, it is reasonable to go to the donor sperm.
Makes sense. Makes sense. So I just want to ask question, but anyway, Dr. Deepak sir has asked, what are the markers we need to investigate in a infertile male, indicating that PRP shall be an ideal treatment? So I want to add a few things before this. So before you both answer this question, because Dr. Sarabit was telling about a sertoli cell only syndrome. Is all SEOs are equivalent to a YCMD positive, like parameters, sir? Because we test for YCMD. So when there is,
YCMD.
yeah, so when there is YCMD, can we presume it is SEO or
No,
something else?
YCMD again, it's of three types, A, B, and C.
Yeah, understood.
So if it is a C deletion, so it's a good deletion. So you see sperm in C deletion. So it's
Yeah.
very simple to remember.
Yeah.
Whereas in A and B, the chances of sperm retrieval are less. I think in B is, I think, indicative of Sertoli cell syndrome, and A is indicative of a poor prognosis on testicular intervention like a TESE or a TESA or a micro-TESA. So,
So to add to
depending
Dr. Deepak Jumani's question, we can say YCMD B can one of the indicator. If YCMD B is positive, we can avoid PRP.
chance. I'm not sure about PRP, sir. Never tried it. So till the time it becomes a conventional therapy, or till the time there is more work done by, I really appreciate the work of Dr. Anna, who is, venturing into a new branch. So if the results are evidence-based and conclusive, we will also definitely like to try PRP.
Dr. Anna, your take on this? Any other markers that you would like to do in infertile men before giving PRP to assess the efficacy? Pre-procedural markers.
Any markers? We just assess spermogram, and that's all before
That's
the
it. Okay.
procedure.
But as for the
Spermogram also, we assess man only in conjunction with his wife, because we need to make it simultaneously and flexible in order to put the cells into embryo laboratory at the same time.
So I would like to add a point. If you are looking at the markers, number one will be the FSH level, which is then the testicular size, then maybe inhibin levels are also indicative. And I think these three things will kind of, guide you. And plus, I mentioned some things affecting the testicular spermatogenesis, like, nutritional imbalance and exposure to heat, ionizing radiation. Whether the milieu is in place, you have to verify that. So it might be a case of cryptorchidism and you are giving a PRP shots, it will not help. Or if he had a mumps in his childhood and he has a history of orchitis, then probably things will not help. So those things have to be ruled out, and then a new therapy. That was the main crux of my presentation, the testicular microenvironment, it has to be in place for any PRP or any therapy to, be successful. So you have
So,
to
are you
correct the
suggesting that we
value
should
first, and
biopsy?
then go for, sorry.
Are you suggesting that we should do a biopsy in these patients before
No, no,
injecting
no,
PRP?
no, I'm not suggesting that you should do a biopsy. No, not at all.
So, how to
I'm
see the environment
saying,
then? Those
see, there are many factors which influence spermatogenesis. So those factors should be checked and they should be, in place, because any intervention will work only if the microenvironment is okay.
should we check the
The
those
person
those
might be
environment
the
biopsy?
person might be standing for long hours. He might be working in coal mines, and you go on injecting PRP, it won't help. His scrotal temperature is almost 37, 38. He's exposed constantly to 40 degrees. So in those cases, PRP won't help, but a reversal of temperature exposure might work for him.
Understood, sir. But my question, because people say that a test tube biopsy is not advised. This is the common claim.
Not
Don't
advised
do
for whom, which patients?
no do for any infertile patients, because you do a TISA with only when there is a cryopreservation facility is available.
Yeah, true.
That is to say, so with the intention of doing the cryopreservation, we can do this biopsy also, send the samples for histopathology, and so we can see whether it's a SUO or a hyperspermatogenesis or maturation arrest or tubular hyalinization. So depending upon that, we can decide whether we can give PRP or stem cells. So this could be one of the ways where we can plan.
Yeah, I agree with you. I think you're right in a way. Yeah.
Dr. Anna, your thoughts on this? This is my suggestion for Dr. Deepak Jiwani's question. Because you are having a cryo bank in your center. So would you suggest to do a trial TISA or trial TSA? So depending upon the presentation. And if there is a sperm, you can cryopreserve. If there is not sperm, so if there is no sperm, you can send the sample for histopathology and assess the micro architecture as sir has told. So based on that, we can decide whether we should go for PRP or we can directly go for a stem cell therapy. This may be one of the marker apart from the YCM, which is non-invasive. This could be one of the invasive marker, because we always say regenerative medicine is a cellular pathology. That is, sorry, a cellular pharmacology. But we should see what is happening in the cells. Then we should try intend to change what is happening to the cells. So that is what, as a
Yeah,
regenerative therapy specialist, we believe
So,
in that. Please proceed. Yeah. Sorry.
so you hear me well, yeah?
Yeah,
It's,
yeah.
fine. Thank you. We use the techniques of biosol with histological evaluation, but we usually at first try non-invasive techniques, and according to the spermogram hormonal panel of men that is temporarily can be changed during the treatment, and we at first do non-invasive, but really there are some individual cases when it is really reasonable to start with biopsy and then histopathology, and afterwards decide what treatment is needed to this patient, or is it needed at all. Maybe it possibly can be not relevant if it is turned out that this state of patient, it is caused by some congenital syndromes, and that they didn't have any manifestation during his whole life, 35, 40 years. And now when he started to think about family, it has turned out that it's just not possible. So we will not do the procedures that will 100% not helping, and it will be just waste of time and also psychological stress. So that's really unnecessarily, and that's better to explain to patient the situation, because this type of communication is really difficult for both for doctor and for patient, for man, for his wife. So when it is nothing to do, why should we make this worse? So
Understood.
that's really unreasonable.
Fine then. So we have come to the end of the session because it is almost 9:30. And if there's no question from the audience, and we can close the session from here. So thank you everyone for presenting, for being patient all the way. Yes, sir. Please present.
Thank you, Dr. Natish, for the opportunity. Thank you.
So thank you, Dr. Sarvil Singh, sir, and Dr.
Thank you.
Anna Peskova from Ukraine. So we'll be conducting most webinars, and we are planning to bring in the pathologists next time to see what are the changes happening in those patients who are infertile. And we will have to present. We are requesting them to present the various histopathology in different presentations: azoospermia, obstructive, non-obstructive, and region-wise. So article which I have read, no, in Pakistan there is one kind of presentation. In North India there is one presentation. In Saudi Arabia there is one kind. So whether what is the cause, as Sir told, based on the cause, I think the pattern is changing. So if you say that PRP is not working for the patients, we should evaluate, we should go back and see what has caused this infertility. Then we should be able to assess the outcome also. Anyways, so thank you both of you for sparing a valuable time in preparing and presenting the all the education content to the audience. And once again, so good night everyone. So next until next EOS, that is Explore Open Series, a symposium. Thank you. Take care.
Yeah, thank you. Good night.
Night. Good night.
Thank you so much. Wish you nice evening. Take care.
Take care then. Bye bye. See you.
Thank you, Dr.
Bye.
Thank you. Good night.
Bye.